Am I already sharing? Yes, I am sharing. Okay, perfect. And then just do. Okay, once again. Okay.
Don't you already have enough living things to take care of?
So, let's go ahead and get started. The benefit of doing this today as opposed to Wednesday is that I know people didn't have a chance to review. So you get all of the benefit of like that horrible, I don't know, sympathetic response that helps our memory, but none of the responsibility for not knowing it, right? So you're welcome. We are not going to do pancreas in this one. That's going to be a separate lecture. So this is going to be liver and biliary, mostly. And then before I realized that, I put a little spleen. So we'll see as time permits what we can get through. So we'll start with the liver first. And we're just going to do a lot of quick fire. I don't have questions in here. You guys can go through score and do liver questions just the same as I can put them up. We're just going to go over what I think is the most high yield stuff and what I think I need review before the ABSITE for. So what anatomic structure separates the right and left lobe of the liver? Katie. Oh yeah, sorry. I'm also have no problem selecting people. So get ready. Cantley's line, right? And so you can follow the middle hepatic vein, and that's going to be the anatomic intrahepatic structure that separates the left and right lobe of the liver. Most common origin of a replaced right hepatic artery. Perfect. Branches off the SMA. Most common of a replaced left. Nice. And that travels in the gastrohepatic ligament. All right. So we're going to talk about liver abscesses, which are rarely seen in practice, but often seen, almost always seen on the ABSITE. Pyogenic abscesses are the most common. I didn't really do this well for a quick fire, but this is most commonly secondary to a biliary tract infection. A common question I see is what is the most common organism? So that's going to be E. coli, not Klebsiella, E. coli. And this is a GI source. You're going to manage that with a perc drain if necessary and antibiotics. For an amoebic abscess, and we're going to go over the radiographic findings for these in a little bit. Amoebic abscess commonly is someone who's traveled to a country like Mexico. You can get anti-amoebic antibodies, and you're going to treat that with Flagyl. This rarely needs drainage. In a echinococal abscess, this has the classic double-walled cyst, like the daughter cysts, calcifications on the CT scan. You can get an ELISA or an indirect hemagglutinin test, and you're going to manage that with an azole, like albendazole, followed by perc drainage if necessary. And then this is going to be the one, quite frankly, you can get anaphylaxis with spillage of a amoebic abscess as well, but the one that's tested is technically the echinococcal cysts. And so you have to be very, very cautious with perc drainage and or intraoperative drainage of these things. I actually don't think I've seen that on the test before, so maybe this is the year. Let's talk about portal hypertension. How do we define that? What test do we do? Daniel. GI will do it. You're going to measure the hepatic vein pressure gradient. So they're going to do that where they get a wedged hepatic vein pressure and then a free pressure. And then it's the gradient between these two things. And then portal hypertension is defined as greater than 6 millimeters of mercury. I've seen this on the exam before. The pressure typically required for a variceal rupture is going to be greater than 12. I think that would be hard to test with just like a specific number. Okay, so related to that, management of acute esophageal variceal bleeding. So first and foremost, right, this is when you have to be an astute test taker. Read the question. Are they saying what is the first step? What is the next step, right? Read the question carefully. First thing you do, you resuscitate, you transfuse, large bore IV access, etc. You are going to give antibiotics. You're going to intubate them if they're ill and need it. You're going to put them on a octreotide infusion, and they're going to undergo an endoscopy for bleeding. You can use one of the Blakemore tubes as a temporizing measure if necessary, but you want to get these guys to endoscopy. So when is TIPS relevant to a variceal bleed? What can happen as a result of TIPS? So this is pretty high yield. What is a contraindication or a caution with TIPS, specifically related to someone's cirrhosis? Awesome, perfect, right? So we might employ a TIPS for acute or recurrent variceal bleeding. This is after you temporize them, right? We're not taking anyone dying up to IR for a TIPS. Refractory ascites, you can do it for Budd-Chiari syndrome, hepatic hydrothorax. I imagine you're probably going to see it on the exam for recurrent variceal bleeding, and this can worsen hepatic encephalopathy. There's all sorts of older shunts that were done surgically prior to IR really coming into play. I think I've seen a question or two. If you're looking for like 95th percentile, review that before the exam. There's a page in the ABSITE book. Otherwise, I'd say it's probably fairly low yield, both on the ABSITE and in real life. All right, what are the components of the Child-Turcotte score? Ah, perfect. Or prothrombin time, INR. Mel-DNA. This is an intern question. Thatcher. So yeah, albumin is not it. So it's Billy INR, creatinine, and sodium. Billy INR, creatinine, and sodium. What MELD score confers a survival benefit with transplant? 15. I haven't seen this question before, but if I was an ABSITE writer, I think I would make it a question. So when someone has a hemangioma, they can develop a consumptive coagulopathy. Remember, these are hypervascular lesions and thrombocytopenia. And so you can develop this coagulopathy within that lesion, and people can get very sick, and that would be a potential indication for a resection. Remember, hemangiomas are normally left alone. So I think this would be an interesting test question because you'd have to know the specific management of this condition. And it also teaches you a little bit about that type of tumor. So, ooh, that's a good addition. Okay, Dr. Vreeland loves this question. What is the hepatotoxicity associated with oxaliplatin, a chemotherapy for colorectal liver mets of the liver? That's probably PGY2 and above. So he has a way of remembering it. Like there's a blue ox, like, I don't know, there's a older story that I don't think, Paul Bunyan, thank you. I don't really know about Paul Bunyan and blue oxes, but if that helps you, you can have associated sinusoidal dilation. Meanwhile, irinotecan causes steatohepatitis, and this can be worse in obesity. So remember this how you will. The reason why I think this is important is if someone has had chemotherapy for colorectal liver metastases or another intrahepatic met, that has downstream consequences for your functional liver remnant, and so it can cause hepatotoxicity. And so you have to think about that when you're thinking about planning your liver resection. So these are two side effects that I think are very clinically relevant too. Okay, speaking of, what is an adequate future liver remnant for someone with a normal liver, Pranav? Yes. What about if they've had chemo? You'd say 40. Okay, I'd say 30. But I think 40 would make everyone feel better. And then what if they have cirrhosis? 20, 30, 40. 20, 30, 40. I think 20% of a liver is going to make a lot of people nervous, but this is the answer on the exam. All right, what if you have someone with HTC and they're very young? This is young female, say it's me. That's a little dark, but right, I have HTC. I promise you I do not have cirrhosis. What variant might I have of HTC? Fibrolamellar, yes. This can be a very, this is a lesion very amenable to aggressive resection, again, because we're presuming my liver is healthy. All right, liver anatomy. This was supposed to be hard. No, hold on. We're gonna go backwards. Who can tell me the segments of the liver? There are 8 segments. All right. What is this? All right, so everyone, there's like a way you remember this with your hand. I don't think that's, All right, would you like to come finish this? No. All right, so how I remember this, right, and this is just find your own way, 1, 2, 4A, 4B, and then I go like a clock, okay? Like a clock. Because these are very tricky because this is a three-dimensional structure I'm trying to represent in a 2D format. We are not looking at 7 and 6 really when we stare into a laparotomy incision. So these are in the back, right? So you see these, this can be tricky, right? This is 8, this is 5. Think of it like a clock face. You're going around the clock. Does someone else have a easy way of remembering it? Michaela, you like the fist? Do you want to explain it? Do you guys have a good way that you know your liver segments yet? You do? Tell us.
Segment 1 is the thumb.
Say it louder.
Segment 1 is your thumb, and then 2, 3, 4A, 4B, 5, 6, 7, 8.
See, but I don't understand how that helps you because you still have to know where all of the segments are. That's fair.
Between the left and the right, the medial thing is actually 4A, 4B, that always has to do that. And then
Yeah.
it's about the left medial or the left lateral. Yeah, I think get that questions about like when we do a left segment.
Yeah. Yeah, that's fair. However you wish to memorize it, there's always a question about liver anatomy. And so that's a good thing to either have. There's different ways of kind of remembering last minute things for the ABSITE. I always have like a little piece of paper that I review every year that has things that I easily forget that are just memorize these and forget it afterwards. You should know your liver anatomy. I wouldn't necessarily put it in that category, but that might be something that you can review right before the exam. Speaking of some of the things that are kind of hard, sometimes they'll ask you straight up what segments are removed with each of these resections. If you know your anatomy, this makes a little bit more sense. Again, extended right? So it's going to be 5 through 8. And then it's also going to be segments 4A and 4B. This is something else to review right before the exam too. All right, key imaging characteristics. I think these can get overcomplicated in some of the review series. I would also say that Behind the Knife on their YouTube channel has a really good series of videos that are like high yield topics for the ABSITE that I think, one, are very good, and two, sometimes it's just nice to have a little bit more of a different way of studying when you're, sick of doing questions. So I would definitely review that. They go through some of this. These are kind of some high yield points. So for a hemangioma, the radiographic finding that's going to clue you in that this is a hemangioma is its peripheral nodular enhancements. So think about this, right? A hemangioma, there's like weird hypervascular, hypervascularity. There's going to be vessels on the outside. That seems to make sense for hemangioma. That makes sense. And those fill first, right? So peripheral nodular enhancement, that's a hemangioma. An FNH, focal nodular hyperplasia, rapid arterial enhancement with a central scar. It goes from outside to in and the scar fills late. Well, that makes sense, right? A scar is probably hypovascular. It makes sense that that fills later. I don't think anyone really has a problem remembering that one, to be honest. Bright on EOVIS, I've never seen a question really asking about that. I have also, sulfur colloid is discussed in a lot of the ABSITE review. I've also never seen a question on that either. Meg's shaking her head also. So maybe that's more of an antiquated study now that we have EOVIS. But for whatever it's worth, the FNH is made up of normal cells. And so this is a differentiation between that and adenoma. FNH can look like a fibrolamellar variant. Some of the differences I think are MRI specific, and I think that's honestly beyond the scope of the ABSITE. They're going to make these really obvious. These are always pretty obvious. Adenoma, these have pretty poor defining characteristics. I'd look for OCP history to kind of help you, but I've also seen an ABSITE question where they throw that in as a red herring, so you can't anchor on that. These are going to have arterial enhancement with washout on portal phase. And these are going to be dark on your EOVIS study, and they don't light up on sulfur colloid. So I think that's probably one way they could ask you about that. Let's see, what do I have? Cysts are really easy. Because they're bright on T2. So T2 is slow moving fluid, just like bile ducts. So I could see them asking about that, but I think a hepatic cyst is honestly pretty obvious usually on imaging. And then whenever you think about cholangiocarcinoma or metastases, these are generally hypoenhancing with little early peripheral enhancement. I think usually how I see these is they'll ask about hemangiomas, FNHs, and HCC, which we'll talk about in a second. Some of these other ones that are a little bit more advanced, I haven't really seen a lot of questions about.
Did you ask about HC?
It's almost like I have a whole slide for that in a second. Agree, they do, and there's a whole scoring system for that we're gonna go over. Yeah, I would just use your history probably for metastases. And that's just a little point about neuroendocrine tumors. Hypervascular on arterial phase is gonna make you think about both HCC and neuroendocrine tumors. All right, criteria for resection. I think this slide is a little out of order, but good things to review are the Milan criteria. And then I haven't really seen them ask about the San Francisco extended criteria. The Milan criteria are pretty high yield when it comes to colorectal liver mets. Review that before the exam. I think this kind of got out of order a little bit. Let's do this. All right, so for HCC, CT imaging, these are hypervascular lesions. What's the other lesion we just talked about that's also hypervascular that can be mistaken? Neuroendocrine. So you got to look for your history, right? So if you have someone like a 65-year-old male with a heavy drinking history or may or may not have cirrhosis, really should have cirrhosis if we're talking about HCC, that's HCC, okay? So use the context clues to help you. And then you're going to get washout during your delayed phase. LIRADS is a scoring system, so think about BIRADS, TIRADS, LIRADS. And the major features are that there's arterial phase hyperenhancement, which we just talked about, non-peripheral washout. These tend to have a pseudo capsule, so they're kind of well defined. This may be a large lesion. And then there's going to be what's termed threshold growth, but basically these are lesions that will grow. Again, LIRADS applies to patients with HCC, and this needs to be in the context of someone with cirrhosis. And so based on someone's LIRADS score, which we can see kind of summarized here, this will help provide a scoring system to give some help with management, basically. I've never seen, nor would I ever expect this specific chart to be on the ABSITE. What I would take away from this is that these are the major features characteristic of HCC on imaging. And so I think these are very high yield. You're not going to be given some sort of LIRADS 3 probably and asked what specifically to manage that. Here we go. Criteria for resection. There you go. All right. Questions about any of that? Again, go home and do some practice questions. Biliary, quick fire, structures in the portal triad and their anatomic relationship. I didn't hear that, sorry. CBD is lateral. Hepatic artery is medial. Vein is posterior, agreed. That anatomic relationship I've seen show up a couple times. Who may benefit from a prophylactic cholecystectomy? However, on the ABSITE, people with sickle cell, large gallstones plus minus, typically they're getting imaged and they find that, and so that may be why you may offer it. Large polyps, question mark, known gallstones undergoing bariatric surgery. I don't really think that we typically practice that, quite frankly, clinically, but this was in the review book, and so it bears mention. I haven't seen that show up. Yeah. But that's, take that for what you will. Have you guys seen that? I don't think so.
Since it clinically is not actually associated with injuries.
Yeah. All right. Pranav, something that is clinically relevant, because we did it yesterday. What if you can't see the hepatic ducts on an IOC? Right, let gravity be your friend. You can push some morphine that tightens up the sphincter of Odie, and so that will help backfill What else? Oh, pull the catheter back and try flushing again. Sometimes you're lodged in the CBD as opposed to the cystic. And then, always, right? If you can't get a complete cholangiogram, you need to suspect an injury, and kind of work that up as appropriate for the clinical situation. I would be shocked if they didn't make that very, very obvious on an exam. I will also say that there's a big push for, the safe cholecystectomy. And so I would imagine we're probably going to get questions this ABSITE and maybe next year too about safe cholecystectomy. So I'd have those algorithms really sharp in your mind. When is an ERCP indicated for gallstone pancreatitis? I pulled this out of an ABSITE book.
There's some lab values, like AST over 500 and over 5 or 13.
So that's for choledochal lithiasis. For gallstone pancreatitis, we really err off of prophylactic early ERCP because there's no clinical benefit. Now, if someone has signs of cholangitis, then that's different. But don't select like ERCP for management of gallstone pancreatitis without any additional indications on the exam that they need clearance of the biliary tree. All right, how do we manage gallstone ileus? Exactly. So the key there is that you defer the fistula takedown unless the test really makes you think that their gallbladder's really sick and so absolutely needs to be removed. They need to be super duper stable. I would probably say that in terms of ABSITE management of gallstone ileus, I would purely milk the stone back and defer cholecystectomy and fistula takedown. Okay. What's the pathophys and management of Moritz syndrome? What is Moritz syndrome? Okay, say it louder. Okay, that was still a whisper, but you are correct, right? So it's external compression of the CHD from a stone in the cystic duct. Typically we manage that with cholecystectomy, but if there's erosion into the common bile duct, you need to be prepared to manage that. And so if there's a large fistula, you may need to do a reconstructive operation. These are very challenging cases. Gallbladder carcinoma. This is very high yield. When is a cholecystectomy sufficient and when do you need to do a greater resection? And what is said greater resection? Joe. Right as you drink.
For T1A is when it's cold, when it's acceptable to just do a second.
Agree.
And then for when it's T1B, so it's through the pathway appropriate into the muscle, right? Appropriate.
Into the muscle.
That is when you have to do extended resection to include a lymphadenectomy of 4A and 5.
4A, 4B.
Sorry, 4A.
Yep. And the term is radical cholecystectomy, which I didn't write there, but 4B, 5, I misspoke, you were right, 4B and 5, and portal lymphadenectomy, don't forget the lymphadenectomy. This is antiquated, don't resect the port sites. I've seen that show up on the ABSITE. The thought was that those were pro-inflammatory and so those may be sites for cancer. That's fallen out of favor, don't resect your port sites. For higher T staging, do a diagnostic laparoscopy first to assess for peritoneal spread. And that should be sufficient. I'd say if I was going to ask a question about this, I would say that you have a lesion and I would give you the path report. And so you have to know the T staging of gallbladder carcinoma and how to manage that. And so I'd review that before the exam. 4 weeks after a car accident with a liver laceration, someone comes in with an upper GI bleed. They have an EGD that shows blood from the duodenal papilla. What'd you say?
Oh, go for angio.
Yes. Hemobilia from a hepatic artery biliary duct fistula, treat with angioembolization. Again, something that I think, I've never seen this and I don't think I know of anybody of us who've seen this, but this is sometimes shows up on the test. Management of gallbladder polyps. If they're symptomatic, yes. If they're asymptomatic, if it's greater than 6 millimeters, you can offer them serial surveillance or surgery if they wish to avoid surveillance. And then you can take them for a cholecystectomy if it's greater than 10 millimeters, or if they have concurrent stones. And there's a concern for risk of malignant transformation in the setting of concurrent stones. And so that's why. What are some risk factors for cholangiocarcinoma? I don't know if that's there, but I'm sure you're right. There's one that's fun, and it's liver flukes, PSC, choledochal cysts, which we'll go over, cirrhosis, bile duct stones. I bet smoking is associated. How could it not be? There's some mutations. I'm not going to ask any about one about these. Just like put these aside in your mind. These are associated with cholangiocarcinoma. You're going to manage cholangiocarcinoma. So I would back up and say that this can get complicated very quickly. And so this is a simplified approach for the ABSITE that we're just going to walk through together. So if it's intrahepatic, right? So the cholangiocarcinoma within the liver, you're going to do a hepatic resection and you're going to aim for an R0 resection. R0 resection refers to microscopically negative margins. If it is extrahepatic, you're going to do a complete resection of that lesion of concern with negative margins and a lymphadenectomy. If you have a hilar cholangiocarcinoma, right, so it kind of is in the middle of both of those things, you're going to do a hepatic resection. You're going to resect any involved extrahepatic bile ducts, and you're going to reconstruct with a Roux-en-Y hepaticojejunostomy. So that this gets complicated very, very quickly. This is a very simplified algorithm, but I think this is probably sufficient for ABSITE test taking purposes. If there are lymph nodes past the porta hepatis or Mets, you will not be resecting this, right? That is unresectable disease. Does that all make sense? Okay. And then if this is distal, right, so approaching the ampulla, you may need to do a Whipple. All right, choledochocysts, unfortunately, these are very high yield for the test, and these are asked every single year. And then the management of said choledochocysts are also very high yield as well. So there's some really good pictures online. This is always something that's on my little cheat sheet for reviewing right before the test. Type 1 is this fusiform dilation of the extrahepatic biliary tree. Ignore type 1A and type 1B. I don't necessarily think that the difference between those two is testable. You're going to resect those with a hepaticojejunostomy. For a type 2, where you have a saccular diverticulum of the CBD, Caitlin, how do you think you can manage that? Diverticulectomy, yes. For a type 3, so this is kind of commonly referred to as a choledococele. There's things that we do in practice. There's things that I think are testable. Goey, what would you do? Yeah, so you can attempt a transduodenal resection. There's some thought that maybe an endoscopic drainage may be an alternative. However, the surgical approach to this would be a Whipple. I would say that in kind of an evolving area such as this, I think the ABSITE's going to make it very obvious and not give you 3 of these to choose between. All right, type 4A, so you have multiple dilations of the intra and extrahepatic ducts. So 4A is right here. How are we going to manage that, Michaela? Yep, exactly. Hepatic resection with biliary reconstruction. If you have multiple dilatations of the extrahepatic ducts, that's also an excision and hepatico-J, just like we talked about above. And then if you have Crowley's disease or multiple dilations of the intrahepatic ducts, Gabs, what would you do? Yeah, usually transplant. If this is like focally and only a portion of the liver, you could attempt a partial resection. I think the ABSITE would also make that abundantly clear too, if they were to ask you that. So to my point about, yes. Yes.
So the difference between type 4A and type 5 and the reason for the resection is 4A is usually confined to only one part of the liver, whereas 5 is.
That is my understanding. All right, to my point about how I think bile duct injury is gonna start to show up more and more with the emphasis from SAGES and some of our broader organizations for the safe cholecystectomy, I have a slide on this. So you are a community surgeon and you have discovered from your IOC or some other means that you have injured the, common bile duct. Maria, what would you do? Yes, remember to drain, but absolutely, if you do not have the expertise to manage this, you're gonna refer it to a tertiary center with an HPB surgeon. All right, you are at a tertiary care facility. Fahey, what are you gonna do? Yes, yes. So now we're gonna get into how you would manage it. So we're going to assume we've called for help. We have an experienced HPB surgeon with us, and we're gonna manage a small and sharp injury. How would you close that? I gave it away. Are you gonna close it vertically or transversely? Transversely, because you don't want to narrow the bile duct, plus minus a T-tube, and this approach varies. If this is large or with cautery, how might that change your approach, Flynn? Yeah, do a reconstruction, agree. Large and or with cautery, the worry would be if you primarily close this, this won't hold. You know, go back to the basics of our surgical principles, resect and reconstruct. All right, unfortunately, let's see, Pranav, in 10 years, you did not recognize that you had a biliary injury, and so your patient comes back 48 hours later, and they're profoundly ill. What is your next step? Call for help is good, but you're going to drain. The main point here is that you forego definitive repair at this point, right? They're ill. You're going to drain, and you're going to defer definitive repair for several months. I think that is very high yield. This is not somebody that you take back to the operating room for a reconstruction. Drain, delay repair for 2 months or greater. Okay, how are we doing on time? I know that this is a little bit of a fire hose. Let's go. Do you want me to go over spleen, or do you want me to let that be? I didn't see anyone assigned on the calendar. Okay, yeah. We just have some quick fire stuff. I don't see a lot of spleen, honestly, on the exam. There's some, I don't know if I really love the behind the knife audio review on this. So these are just some quick hits from their book, which I think is very good. What is the most common splenic tumor, Katie?
Is it
No. What else? Meningioma, yes. And you're really only going to resect this if they're symptomatic. What are some risk factors for splenic angiosarcoma? Daniel. There's a really like classic one. It's probably either know it or you don't. And that's why we're doing this, right? So vinyl chloride exposure. Yeah, we're all like, oh, I remember that from step 1. Okay, what is the most common organism associated with OPSI? Yeah, perfect. Excellent. The most common source of post-splenectomy bleeding? Short gastrics. Someone has abdominal pain post-splenectomy, a low attenuation contained fluid collection in the lesser sac. Couple? I heard it. Pancreatic leak. Yes. You're going to do a perk drain for this. Someone's presenting with fever, hemolytic anemia, renal failure, purpura, and neuro changes. What's the diagnosis and how do we treat? TTP, I always have to review these. This is caused by Adams TS13 metalloproteinase. You treat that with plasmapheresis. And then there's a lot of mnemonics for this. I didn't write them down. This is something that's on my sheet for reviewing before the exam. All right, if someone has isolated gastric varices, what is your suspicion and how do you manage it? Splenic vein thrombosis, splenectomy, yes. All right, when would you do a splenectomy for someone with a splenic abscess? Yeah, so I would say multiloculated or multiple splenic abscesses, absolutely splenectomy. If it's thin walled, which basically implies you can't get a good perk drain, then that's something else that I would consider a splenic abscess or excuse me, a splenectomy for. All right, some anatomy questions. This was actually on last year's ABSITE, I think. But I wrote the answer, so that's a shame. So the splenic artery is going to run superior to the pancreas. The splenic vein runs posterior or within the pancreas. So artery is superior, vein is posterior. For whatever reason, I think that makes sense or is easy to remember. What is the pathophysiology of ITP? Yeah, autoantibodies, and they're these are to the glycoproteins. How do we manage ITP? Nice. Yes, IVIG and steroids. If they're refractory, you can manage this with a splenectomy. If someone has a positive response to steroids, that is a good prognostic factor for improvement with a splenectomy. When in your operation, would you give platelets for bleeding for someone you're taking to the operating room for ITP? After you take the artery, absolutely. Because if the spleen is just going to chew it up, then you're not doing any good. And this is only done for intraoperative bleeding. You're not going to give prophylactic platelets. All right. What findings on a smear suggest an absent or damaged spleen? So what do Hal Jolly bodies signify? I always forget these. Yeah, nuclear remnants. What is a target cell? What is a Heinz body? Denatured hemoglobin. Nice, guys. Spur cell. This is the deformed membrane. And then that's it. All right, that was great. Good job, guys.
Great job. Like making it from my gosh, about that.